My name is Ed Trujillo, and I'm a customer success member for Classy. Thank you for joining us here in today's showcase. We have here, I gotta take notes because this is a lot of stuff I gotta read off. Today's showcase is Social Innovators Driving Access to Health. The three leaders we heard from today have dedicated themselves to increase access to health services, programs, and products in the US and around the world. First up to the stage is a dynamic duo. By the age of 15, Liz Eddy founded her first social venture, Sisters on the Runway. After graduating top of her class from Parsons, the new school for design, she ran special projects for DoSomething.org. In 2015, she became and now serves as the Director of Communications for Crisis Text Line. She's an active volunteer and board member for the Experience Camp, 1 week free summer camps for children who've lost a loved one. On her free time, she's in search for the world's spiciest foods. And with her, we have Tessa Shapiro, who works as a crisis counselor coach at the Crisis Center Text Line, where she leads a team of 500+ volunteer crisis counselors. Before joining Crisis Text Line, she graduated with distinction from the University of Michigan in biopsychology, cognition, and neuroscience. She is passionate about improving quality for all children's access to mental services, mental health support, and quality education. You can find her often exploring New York City's new coffee shops and restaurants. Table for two, please. Without further ado, please welcome to the stage Liz Eddy and Tessa Shapiro.
Hello. Good morning.
Good morning, everyone.
How's it going? Good, great. I love how nobody sits in the front.
Of course not.
Well, welcome. Glad to be here. I just got off a train, so I've been on the train for about 5 hours, so I'm glad to be here. So we're going to tell you a little bit about Crisis Text Line, and honestly, we are super informal, so if you have a question in the middle of it, just yell at us and we'll answer it. So this stat, completely terrifying, right? 65 million Americans suffer from mental illness every year. And the reality of it is it's just becoming more troublesome with healthcare changes, accessibility to mental health support, lessening of counselors in high schools and universities. There's really a need for something simple and accessible that people can get mental health support right when they need it. So this is a lovely little map from SAMHSA. And if you look up at the top, the red is 8 to 10% of suicidal thoughts in young adults. So 8 to 10% of young adults in the US are having suicidal thoughts right now. That's just the red. And then it progresses to the blue. Oddly enough, in the South, it's the lowest. And the reality of it is this is becoming a bigger and bigger conversation in media as well. So we're seeing suicide clusters in Palo Alto, for example. There was a huge Atlantic article about this where there were networks of young people that were killing themselves in schools like Pali High School in Palo Alto. We're also seeing shows like 13 Reasons Why coming out on Netflix, and Dear Evan Hansen on Broadway, which just won a bunch of Emmys, and Tonys. Thank you. I know a lot about Broadway. Tonys. And this is just building this conversation around mental health in the US. So there's a really simple solution to this, and it's Crisis Text Line. So the idea came from an edge case. We were working at DoSomething.org, this was 5 years ago, and we got a text message to Do Something, which is the global organization for young people and social action. And it was a conversation that was unexpected. So usually people text us about campaigns, so things like food drives or clothing drives or how to help animals in shelters. And we started getting text messages about suicide, about bullying, about not wanting to go to school. And this is, it was a text line that had nothing to do with mental health, and yet young people were using it for exactly that. And we got one text message one day that we didn't know what to do with. We brought it to our CEO and said, I don't know what to say to this. And it was a young person that wrote to us and said, he won't stop raping me. It's my dad. He told me not to tell anyone. Are you there? Now remember, this is a text line that has nothing to do with mental health, and this person was in such a desperate place that they didn't know where to turn to except for complete strangers. And it made us realize that this was a form of communication that young people needed to be able to expose this information and find the next steps and the validation that they needed to get help. So enter Crisis Text Line. We started about 4 years ago. And the idea really came from trying to find something that young people trusted, that was easy to use, was accessible, was private. A bunch of you I can see are texting right now, and we don't mind. That's okay, because you really could be texting with us right now and we would never know. That's the beauty of it. You can be sitting at a school lunch table, you can be sitting in your office, on the train, and reaching out in dire need, and then getting the confidence you need to take the next steps to get that help. So we launched in 2013 in Chicago and El Paso. It was actually me as a 22-year-old going from door to door at different mental health organizations across El Paso and Chicago, universities, and just saying, please share this number, please let your students know, please let your community know that we're available through text message. And what happened was, within 4 months, we were in every area code within the US. And that was just people telling each other about it. That wasn't us doing any marketing. We didn't have Facebook ads. It was just people using the service, realizing it was helping, and telling their friends about it.
So I'm going to tell you a little bit about how it works. You're probably wondering, it can't really be that easy, but it actually is. So our number is 741-741. It's up the left side of your phone. If you look at it right now on the keypad, it's as easy as it gets. And anyone, anywhere, like Liz said, can text in. And what are some of the things that we see? It's, I want to die. Can you please help me? I'm being bullied. We see everything. And you can start the conversation however you want to start it. There will be no judgments with what you want to talk about. We always say if it's a crisis to you, it's going to be a crisis to us. Who are we to judge what that crisis is? And so the very cool thing about text messaging is that we can triage the conversations that come in. So unlike traditional phone lines who come in with the time frame, so you call in and kind of like a customer service representative, you're going to take the first conversation or the first call that comes. With us, we can triage those conversations using an algorithm that we built to see the conversations that we call code orange. The ones that say, I want to die, that say, I'm cutting in the bathroom, please help me. Those go to the top of the queue. So they're the very first ones that we can take, and then everything else follows. So this is what the process looks like. You have a texter. Like I said, you can be in the bathroom, you can be really anywhere you are, and you can text in anything. Our algorithm triages it, and so that's that first line of defense. We ask, saying, what's on your mind? And you'll tell us a little bit more. And then we have our crisis counselors. These are our bread and butter of the company as well. So we right now have 3,300 volunteers that are volunteering for Crisis Text Line. At the company, I am a coach, so that means I am training our volunteers through a 34-hour, very rigorous training, but all online. So you can do it from anywhere, in your couch, in your pajamas, whatever you want to do. It's super accessible. So it's a 34-hour training where you learn the basics of empathy and active listening and becoming non-judgmental, and then of course assessing for suicide risk and ideation, assessing for self-harm, learning coping skills and strategies for how to get someone from a hot moment to a cool calm. And then we have a third line of defense, which is our supervisor. These are MSW or PhDs, or people with them, and they are in real time supervising our conversations. So line by line, they can read exactly what's going on in these conversations to ensure that every single texter gets the quality service that they deserve and the help that they need. So when Nancy Lublin, who's the CEO, started, she was expecting to get pretty much all conversations on bullying. Texting is, of course, a very youth-centric way of communicating, but now it's really everyone. And we've heard a lot about this. So even this morning, Erin from Twilio talked about the ways that everyone is using text message as a way to get places and to increase your mission. So we have this incredible corpus of data from these text messages, and we're going to kind of tell you a little bit more about what that data uses and how we can see it. But these are the most common issues that we see. So about 35% of our conversations will deal with suicide and depression. We see a lot of conversations regarding anxiety, and we have amazing referrals and resources that we can send our texters that will help them in that moment to get from that really tight-chested, you can't breathe, I'm shaking, to being able to breathe again. And we can see it in the conversation itself, in the language that people use. And so there's some really cool trends that we can see in real time. And the really interesting thing is that this first thing, the time of day. So I've always found it fascinating that crisis centers are open from 8 a.m. to 8 p.m. We all know that crises don't always happen in work hours. That's ridiculous. So we are open 24 hours, and 2/3 of our conversations happen in that late hours at 8 p.m. to 4 a.m. That's remarkable. That before this, there were people that didn't know where to turn to because they were just open from 8 a.m. to 8 p.m. A lot of people ask, what's your demographic look like of texters? Who is texting you? So we skew young, rural, and poor. About 75% of our texters are under the age of 25. Even more staggering is 10% of those texters are under the age of 13. So those are middle schoolers and even some elementary schoolers texting in pain. When I'm not even that old, but we didn't have phones in middle school, so that's pretty remarkable. Poor, we have 19% of our conversations are in the 10 lowest SES area codes, and we know that because when you text in your number with the area code, it's implicit data, it's right there. We don't need to ask you, so, where are you from? Who are you? What's your background? It's just right there in the area code. And rural, we have 5% of our texts come from Native Americans, people who identify as Native American. That is an amazing stat because 1% of all of America is Native American. So very, very cool that we're reaching the people who need it the most, the people that don't have any other access to care, especially mental health care when it's super stigmatized. And we see that top locations are in school. So most of our self-harm conversations are from the bathrooms. And we'll talk about, being home or in the bedroom where your parents don't even know that this is happening, or your partner, maybe you're in an abusive relationship and you're sitting right there. And then today. So this is happening in the moment. This is crisis intervention. This isn't tomorrow or yesterday I was really upset. It's right now. I don't know what to do. I can't handle this. And so we see the really, really incredible impact. So these are actually, we submitted this a few weeks ago, so these are a little outdated because we move really, really quickly. We just hit 40 million messages exchanged yesterday while I was here. And so that was amazing, and it's an incredible landmark. Right now we have 3,300 volunteers, and they are the most compassionate, incredible human beings. If you want to come volunteer, please come talk to me. I would love to talk to you about it. And then we have done, now it's 6,700 active rescues. So this is when someone is at imminent risk of suicide or homicide. That means that they have the ideation, the plan, the means to that plan, and a time frame within 24 hours. If they're not willing or able to safety plan with us, we will get them help. We will call emergency services and get them the help that they need so that they can be alive for one more day.
All right, I'm getting the signal to wrap up. So I'm just going to say one quick thing about our data. So first and foremost, we're a crisis service. We de-escalate. Secondary, we have the largest global corpus of data, the largest in mental health. So what we do with that is two things: open data collaboration, so working with university-affiliated research partners. And second is crisistrends.org, which you guys can check out now. It is our live, real-time data that anybody can see. It shows you things like time of day, days of week, locations, all about mental health. And I can explain that more in questions. So I'll skip over that. That's our info.
Yeah.
Thank you, Liz and Tessa. Thank you so much. We're going to open up the floor to questions from the audience. If you have any questions, please raise your hand and I will bring this mic over.
Hi, my name is Angelica Vasquez. I go to Babson College around here. I have a question on how you deal with scalability. So because it's texting, you have to have a customer service or I don't know what you guys call the people, the crisis management, one-on-one with that person texting. But what if there's the flood of people texting is more than that number? How do you deal with that?
You could talk about volume,
Yeah,
considering
sure.
we've had a ton of it right now.
So yeah, we're actually going through that right now. And that's why our platform was built the way it was, actually. We recognize that with text, there's really no way to judge when you're going to have high volume, low volume. It depends on times of year, it depends on current events, it depends on if one direction breaks up. Like honestly, all of these things have an impact on the text messages that we see. So we built a platform where one, crisis counselors can actually take more than one conversation at a time. So it's very much like a GChat window where you can open up to 5 messages at any given time. So the more experienced you become, the more conversations you can take. And we also have a second level of oversight. So our supervision team, as Tessa mentioned, that oversee all of the crisis counselors that are on the platform. They're PhD license level mental health professionals. They can also take high risk conversations out of the queue as well. And also just what we talked about with Code Orange, so our triaging system. When we're having really high volume, for example, we had a massive spike right after the elections. And what was pretty incredible about that is while we were having at one point 8 times our regular volume, we were still answering high-risk conversations within 1.2 minutes or less.
Hi, thank you. I'm wondering, so what happens after you've texted someone? How do you know what the outcome of that conversation was? Is there a follow-up? Like, how are you measuring your impact?
From our end?
Yeah, so you've sent someone a text, you've had a conversation de-escalate, so how do you figure out what's happening in that person's life after?
So we don't do any follow-up. There's absolutely no follow-up. We will never reach back out. There's a slippery slope with that. But we have a ton of outcomes. So really cool, there's explicit outcomes. So that means we send them a survey at the end of the conversation. How are you feeling? Tell us more. We get thousands of feedback a week from texters saying, you literally kept me alive. I could read you, seriously, hundreds and hundreds of them that are so amazing. You are an angel. Thank you for listening to me when no one else would be there. So that's that explicit data. We hear it from our texters. The implicit data that we can see is the language that's being used in the conversation itself. So you see sad emojis in the beginning of a conversation and thank yous by the end. You see really harsh words used at the top like hate and cruel and alone. And you see at the end of a conversation words like hope and okay, I will be okay, and so listening. So you can see it in the conversation itself, the progression from that hot moment to a cool, calm.
So I was just curious if you had an opinion on the Michelle Carter case. Are you guys familiar with that at all recently?
Oh, with the text messaging about suicide, right?
Right, encouraging her high school boyfriend to take his own life. I don't know if that relates. That's kind of like the opposite of what you all are trying to do. I'm just curious if there's been any discussions at your organization about this, or if that relates in any way, just in terms of communicating or any implications of that at all.
So not, I would say, specifically to the Michelle Carter case, but we have a really cool integration with Facebook where if someone is saying something or posting something that's potentially harmful, that seems like it could be leading to self-harm or suicide, Facebook has created an awesome thing that you can flag that conversation. And something pops up and it says message with a crisis counselor. And so through Facebook, through the messaging app, you can text or you can message with us. So in terms of flagging conversations and getting the help that they need, we really are meeting people where they're at. And so yeah, of course, social media right now is a huge issue for bullying and some precarious situations, but that's exactly why we're here, because in that same medium that you're getting a text like, go kill yourself, you can text us and say, someone is telling me to go kill themselves. I don't know what to do. Maybe I should act on this. Can you help? It's right there. You don't need to pick up a phone. You can literally just text us.
You told us that when you judge someone to be at imminent risk of suicide, you get some emergency help. Can you explain how this works? I mean, how do you know who do you contact? Is this with the consent of the person, or do you just do it off your own initiative?
I couldn't hear the full question.
It's about the active rescue process, sending emergency help, right?
When you said that when you judge someone to be at imminent risk of suicide,
how you
they've
judge
got
if
the
someone's at
plan, the
imminent
plot,
risk.
and the means and so on, then you get emergency services.
Sure. So when someone's at imminent risk, first, our crisis counselors are trained to do a risk assessment. So it's not only the ideation. Our goal is never to send police to someone's house. We'd rather not if we can avoid it. So if it's just ideation, we try to work with the person through this feeling, try to identify other resources. But if a crisis counselor also identifies there's the means, the time frame, and the plan, then that is an imminent risk situation. So the person says, I have a bottle of pills, I'm planning to take it in 10 minutes, and I'm going to take the whole bottle. You know it's an imminent risk situation. In that situation, you flag the conversation, and a supervisor, who I mentioned before is a licensed mental health professional, reviews the conversation, confirms it is in fact imminent risk, and then basically it's a two-part plan, right? So the crisis counselor is keeping the person on the line. They're saying, hey, can you put the bottle of pills away while we continue to talk? And then the supervisor actually is able to access the phone number of the individual and then work with local authorities based on that area code to either identify if the person is in that area or to ping the cell tower of where that person is and identify the location in which they're in. So it's like a little Big Brothery, but in a good way.
Does that answer your question?
We have time for one or two more questions. So
one other thing about active rescues, which is just helpful to talk about, is that we have a way to track them. So it's very transparent. A lot of people talk about transparency right now. And so we built something like the Domino's pizza tracker. You guys have all ordered Domino's, I'm sure, and have seen it. So we now have our active rescues on that same tracker that we built. So is the texter located? Where's the local EMS contacted? And so that way the supervisor and the crisis counselor can know what's going on with their texter.
Hi.
Hey.
Hi. So I know that your focus is mainly in the U.S., but I was just wondering, as far as abroad, with partnerships abroad, whether it be with other organizations or volunteers, do you see anybody?
Yeah, so international is coming, and very, very soon. We actually have a director of international focused specifically on rolling out first in English-speaking countries. Then it sounds like it'll be the Middle East next. And yeah, the goal is to roll out in Canada this year, UK and Australia beginning of next year, and then moving from there.
Hello. What are the legal implications, like if there is a suicide and people get involved with any of that?
I'm sorry, I didn't hear
the legal implications, the legalities.
Can talk to that more.
The legal implications of like someone who completes suicide.
I think the question was on the legalities.
The legal.
It's like the psychiatrist and psychologist, and you didn't catch up this. If you didn't pick up the suicide or whatever, and you didn't help, there's a legal implication there, they can sue and all those kind of things. Is there, it's not because you're a volunteer, it's not in there, or is that it?
Yeah. So the legal implications, it is tricky. I mean, in the society that we live in, whether or not there is a case, there can always be a case. Luckily, knock on wood, that hasn't happened. But we, first of all, have a really strong terms of service that protects our crisis counselors first and foremost. There are laws that protect volunteers who are just trying to do a good thing for somebody else. It's the Good Samaritan law. So if you help someone who's choking on the street, you're not going to get sued if they end up dying from choking. That being said, we do have a very strong legal team in case something like that did come up.
Yeah.
But our crisis counselors are trained to identify these things, and our supervision team, they are licensed mental health professionals, so they're also seeing these conversations and identifying any potential imminent risk.
We have time for one more question, and then we'll close this out.
Hi, thanks so much for this presentation. Big fan of Crisis Text Line. So you talked, Tessa, I think about implicit data and the fact that the area codes, that's how you kind of get that, the data about rural and that. What about the other data points that you talked about? How do you use that data? Are you mining the conversations, or how does that feed back into your system?
Yeah, so we have someone that has built an algorithm to scrub all personal identifiable information. So PII scrubbing is the top of our list of privacy concerns. And so then all of that data that's open for everyone to see has been scrubbed and is looking for the general trends, so things like that. For more specific level data, we have data science engineers that can look at the trends like, trying to give a good example off the top of my head, but
so we have open data collaborations, which I very briefly mentioned, but basically that's a higher level of research that we're able to do. So our data, we have set it up so that we can pull all this information and then basically make it available to mental health researchers. So we're not doing the research ourselves, we're making it available to other researchers. So things that they've been able to figure out and are researching right now are things like, does altitude have an impact on suicidal ideation? What kind of words do kids use to explain child abuse? What are the correlations between LGBTQ laws and hate crimes versus mental health of LGBTQ youth? All these things are being researched right now, and in the next few months we're going to start releasing it, so it's going to be pretty exciting.
Well, thank you very much, Tessa and Liz, for joining us today. Big round of applause.
Thank you.
They'll be around afterwards if you want to meet up with them, ask some questions. We're going to take a couple minutes to just set up the stage for the next speaker. All right. Next to the stage, we have the CEO of LimForge, a 2016 Classy Award finalist. A lawyer by training, Grace Mustali spent her life in public service working for social justice. As a high-ranking career official in the U.S. Department of Justice, she was instrumental in the enactment and implementation of the Americans with Disabilities Act, as well as many other federal laws and regulations. After leaving government for good, she continued to be a force for change, advising on law and technology issues, ethics, organizational health, and corporate responsibility, while bringing strategy and discipline to startups and nonprofit organizations. As COO of General Counsel of the National Coalition of Healthcare, she used data to help drive health system reform. When not being a social justice superhero, she leaves her cape on and rescues animals, goes kayaking, and gets her yoga on. Namaste. Please join me in a warm welcome to Grace Mustali.
Thank you. Can you hear me okay? Thank you all for being here, and count your blessings that you can hear me. One of the things I told Classy this morning was, where's my signer? Look around you during the course of the week. There are very, very few physically disabled people here, and yet we live in one of the world's most advanced, most disability rights and accessible countries. we are going to do a couple of introductions now. We are LimForge. Many of you may have known us and seen us here last year as the Enable Community Foundation. We started out doing superhero hands for kids, but LimForge reflects what we call effective altruism. We are hard-headed, data-driven, evidence-based technology innovator. And during the course of our first couple of years, we were incorporated on October 2014. So we will be around for 3 years in October. Poverty. Let me introduce you to a victim of poverty and disability. This is Dani. Dani is one of our transhumeral amputee patients in Haiti. Dani was a victim of the 2010 earthquake. She managed to rescue everyone in her household and had the rubble collapse on her. The only way she escaped from the rubble was by asking for a knife in order to amputate her own arm. Because the culture about disability, particularly physically visible disability, is so strongly negative. Even her own family disowned her. She was shunned and had no place to go but the displacement camps. It was 7 days between her initial self-amputation and getting medical care. Dani is a survivor, but she's also an exemplar of the cycle of disability and poverty, which is worse in the lowest income countries in the world. So while I care deeply about accessibility for people in the US, the focus of LimForge is addressing the gap in the rest of the world. I'll let you read for yourself, but know that in the vast majority of low and middle income countries, prosthetic rehabilitation that we take for granted after a traumatic amputation in the US and much of the developed world simply is not available. The WHO estimates that it will take more than 50 years of training at the increased rate that has just begun to begin to meet the need for prosthetic rehabilitation in the world. Most of the lowest income countries have no training program. Our strategy is, and this is what this showcase is about, how do you leverage the power of technology, not reinventing the wheel, but making that technology available to address the extraordinary need, which can be the difference in low-income countries between life and death, and provide quality services and rehabilitation. And no, prosthetics are like shoes. You gain or lose weight, you grow, you need a new one. You become pregnant, you need a new one. The functional requirements are, in many cases, changing. So our goal is to provide, through technology, tools, training, capacity building, sustainable, scalable prosthetic rehabilitation to places in the world where it is virtually non-existent and non-available. How? We have one extremely unique thing, which is our innovative software solution. There's a 90-second video that I'll ask you to take a look at, and I'm going to step around so I can narrate it a little. LimForge. You sign on. It can be either laptop hard drive based with updates pushed to you, or cloud based. In many lowest income countries, you can't access the cloud reliably, so we offer both options. You sign on. I guess our video connection is not working. Well, you sign on and you fill in patient information much as you would on hard copy in a clinic. Name, cause of amputation, age, basic measurements, and no Wi-Fi. So much for technology. Good thing we know how to work around it and without it. All right, you fill in the form. You take some basic measurements, or soon you enter the scan, the 3D scan. We're about 3D technologies: 3D scanning, 3D modeling, and 3D printing. You fill out the form. What kind of amputation is it? Click. Okay, the best option for this patient is, it looks like what we fondly call the EBI arm, because one of our first patients in pilot tests and clinical studies was named Ebuelda. You click, you put together the pieces. This is a socket. This is a forearm. This is a terminal device. All right, are we ready to send the information to the 3D printer? A 3D printer is not a solution. It is an enabler for solution. It is only as good as the information, the design, and the quality of materials that go into it. Our mission, our goal, our theory of change is if an aligned action network of community healthcare providers, of humanitarian NGOs, of health systems in the lowest income countries in the world can partner with us as our partners in Haiti, the Middle East, and Africa have done in our clinical case studies, we can use the 3D technology and existing technologies, including SMS follow-up, telemedicine, and our software solution, which basically enables lawyers like me to produce customized, personalized designs that meet the patient need and allow the people on the ground, the technicians and the clinicians, to identify the greatest needs of the patients. 5 minutes, okay. Here is LimForge. I'll let you look through this. We handed out cards. Just so you can show, in Haiti, especially our women patients wanted things that looked lifelike, that matched their skin tone, and addressed some of their greatest losses. Braiding hair, driving, carrying buckets, doing laundry, just being able to ride on the bus because people won't throw you off. So we're use patient-centric design, collaborate with the patients and the clinicians to identify the problems, and we're now past the initial testing. We're past the proof of concept. we're beginning to transition to scale. Here are some of our patients who have now access, because of the partnerships, to, as long as our partners and we continue to be able to operate, to a lifelong continuum of care. They can go back to the clinic. They can get repairs. They can get changes. I don't have a copy of Ebawelda's cell phone hand, but after she got the initial cosmetic hand, after we solved some of the problems of doing this, she wanted a hand that she could just hold her cell phone in. We were able to deliver. In Jordan, with Syrian refugees, we're delivering designs, and we call them terminal devices because you can snap them on and off. The return on the investment, the original design is a screw which matches the International Red Cross standards for terminal devices that can be changed. I can put a split hook on this. I can put a cell phone hand on it. The key part of every prosthetic is the socket. Right now we're focusing on upper limbs. This summer we will move more into lower limbs for sockets initially. Materials have to be able to address the needs and be low cost. Any guess on how much this device might cost to deliver in Haiti? No questions? The materials are extremely low cost depending on the size of the patient. The highest cost associated with delivering this prosthetic socket, forearm, connecting device, and hand is electricity, because you've got to run the generators and pay for unreliable electricity. Even with that, and even with the harness and connectors, it's probably around $25 US. One of the professional prosthetists we work with described the arm delivered in Haiti for Dani as a $10,000 arm. That's what we're about. We're trying to scale. The problem is huge, and it is a life and death problem in many of the lowest income countries. I'd be happy to take questions, and Sam, if you'll pass these around. People generally like to see and touch what we're talking about.
Thank you, Grace.
Sorry for the delay on the video.
We're going to open up to questions now.
Hi, Grace. Question for you on accessibility. Are you running the 3D printers at the location?
On site.
On-site.
Our goal is to train trainers and create capacity within the local communities and within other NGOs. So in Haiti, for example, we started by doing a several-week-long cross-disciplinary training in the only prosthetic clinic. Now we're comfortable and confident that we can move out to other community healthcare providers to provide prosthetic services under the remote supervision of both 3D technology experts and prosthetists. We partner with organizations such as Doctors Without Borders in Syria and Lebanon. We've done working on case studies with Handicapped International. We're working with the University of Rwanda and the International Society of Prosthetists and Orthotists. We're trying to achieve by 2030 many of the cross-cutting disability-related goals as it relates to physical handicaps, particularly amputation, of the UN Sustainable Development Goals. And it's not released yet, but we're totally aligned with the training of clinicians and technicians of the WHO Global Assistive Technology strategy for 2030.
So you're providing the 3D printers to
We
these
provide the
places as well?
technology. We work with our corporate partners to provide the printing. We work with corporate partners to provide the scanners. In some cases, we work with organizations. In fact, Twilio will be part of our feedback process because amputations require a life of care and rehabilitation. The follow-up is important. In conflict zones and disaster areas, it's extremely difficult. We even have sensors in our clinical case studies that are built into the devices in order to track the actual use. Patients lie. It's like when I go to get my hair cut, I tell the stylist I really like it, and then I go home and change it. Well, patients tell, especially NGOs and volunteer doctors, that it works fine, I'm using it every day, I love it. They don't. It may be uncomfortable, it may be a bad fit. So as part of our clinical case studies in our evidence collection, we literally put sensors in with the patient's permission that tell us how much they wore it, what the temperature was it too hot? They say they wore it 5 days a week, they actually wore it to church. So that's part of our, I say we're hard-headed about evidence and data, but we're soft-hearted about trying to solve a problem which will not be solved by training prosthetists in the developed world. Thank you for the question.
Any other questions?
Given the low cost, which is crucial to the whole operation, there's clearly a limit to how useful these prosthetics be. So presumably initially, the aim is to provide cosmetic improvement to the patient's life. But I noticed from the arm that I handled, there was limited thumb movement.
Right.
Is the hope that the 3D technology will develop along the lines of enabling greater sophistication of these?
The cost is a big factor. Each of these has a terminal device that can be removed or attached. They are totally compatible with first world, if you'll forgive me for saying, with developed countries' terminal devices. The cost is a barrier, the shipping is a barrier. Even the traditional way that a prosthetist works in most countries today is more like how they did things 150 years ago. And in Haiti, plaster casting is a problem. It's hard to get plaster that hasn't been diluted with sand. They will wait sometimes 6 months for a split hook that they've ordered online to be delivered. In our work with MSF, or Doctors Without Borders, to most US folks, they only have patients for about 20 days before they're sent back to Iraq or Syria. So we have to come up with solutions that are functional to solve the patient's problems, whether they need to go back and drive a stick shift, they need to go back and be able to do. So we do customized terminal devices for those purposes. We started off cosmetic. The cosmetic requirement is extremely strong in Haiti, in the Middle East, and parts of Africa and South America. Elsewhere, in Nepal, functionality. In Cambodia, functionality is more important than the cosmetic solution. So it's the design and the delivery is very patient-centric. The power of LimForge is that the technician or the clinician can pick from a library of solutions and put together what can be printed to meet that patient's need. Or if they have the luxury of having a split hook on their shelf, they can add the split hook to the solution. I'm not sure. Some of our clinical study patients have multiple devices now, terminal devices to address multiple needs.
Any other questions? All right, well, thank you, Grace. Thank you so much.
Thank you for collecting my bits and pieces.